right, I'm going to go ahead and introduce our next speaker. Francesca Stracke is Stracke. I always pronounce it wrong and then I forget what it was. Anyway, Francesca is a nurse practitioner who works in palliative care at Multicare Rockwood here in Spokane. And she's going to be taking a kind of a different direction than our other two speakers. She deals on a daily basis with people who are facing very complex and serious illnesses and walks with them through a journey that is often quite difficult. Francesca has a passion for people, caring for people. The first time I met her, she told me a story about her neighbors who are elderly and need help. And she's just like, and there's nobody to help them, but there's Francesca. So I invite you to listen carefully. Some of what she has to say is maybe like completely different than what you're thinking, but I think you will benefit from what she's experienced and learned about planning for difficult situations. Thanks, Francesca, for being here.
Yeah, as Cindy said, my role is in palliative care. And if you Google palliative care, you'll see sort of a generic description. It's supposed to be support for individuals at any stage of a life-limiting illness. Sometimes people think that it's automatically hospice. It's not supposed to be. The challenge is it's kind of evolved differently in different communities, so we don't have a lot of resources in this area. We're really limited almost entirely to the hospital setting, which means I tend to see people that are in crisis. They're at a crisis point, not kind of upstream. So I love hearing about, what we're talking about here today, that there's so much we can do upstream if we just kind of are intentional about that. It's just not my experience in my day-to-day work. I do see them in crisis points. I saw a person this week, actually, that had been in the hospital, had probably moderate dementia, and came in, husband found her down in the bathtub, unconscious. They couldn't really figure out all that had been going on. Finally found out she did have an urinary infection that had improved by the time I saw them and they were getting ready to leave. But the husband was telling me, yeah, she's been losing all this weight and having all this diarrhea, and happened to mention how much she loved diet sodas. And I said, yeah, that can cause diarrhea. And he said, well, how come no one's ever told me this? Like, I've been to all these people. He's so attentive. He was showing me all these cameras he had at home, and so he could take care of his wife and motion detectors. And then knew that she had this advancing dementia, but no one had talked to them about it, like, at all. He didn't have an idea. I mean, she was on a couple of the traditional medications, Namenda and whatnot, but no one talked about what happens when it progresses. So my heart and my passion is I have a tender spot for people with dementia that come into the hospital and are in crisis that a lot of my colleagues are less inclined towards, because we see a lot of cancer and heart disease and other things that in our healthcare system get a lot more attention. There are a lot more tests and procedures and expensive interventions that we can provide. And so they tend to get the attention. And then in the primary care world, they're really just crammed for time. So they're not necessarily talking to their patients about this or helping them understand it or identify it. And we don't very often send them any kind of specialist. So, and my mother died over 10 years ago from a vascular dementia when she was only 67. When she was 64 or 63 and a half, she had a stroke and really didn't take care of herself. It wasn't the kind of stroke that should have been devastating and hard to recover from. So I have some personal experiences too. So thank you for being here. And I just want to take a minute to pray before we continue on. So thank you so much for this opportunity to come together and to learn about ways to kind of mitigate and prevent dementia. And also thank you for an opportunity to talk about how to prepare for it when we do have it. Bless these words now in your name. Amen. So kind of what I'll talk about is some common features of the stages of dementia. Do try to do a quick overview there because our other speakers are hitting on this. And this is a very broad definition of dementia, not like Alzheimer's specific that we just heard about, or some of the other Lewy body or frontal lobe. And so they do have some unique things. But what I'll try to talk about is some things to do or prepare for in those stages. And that would be universal to all types. And then I'll talk about the difference between competency and decisional capacity and how it is that we can assess for decisional capacity. We'll talk about advanced care planning and what it is, and some advanced care planning documents such as a post form and advanced directive, and review some specific considerations that are classic to dementia, all different types of dementia as they progress. Talk about what a legal surrogate decision maker is, because if you have no advanced directive, then there's a law kind of that affects who makes decisions for you. And then I do have a couple of links, so the PowerPoint that were handed out, to just advanced care planning videos that are free to access, because there's a lot of advanced care planning resources out there that are rather expensive, but I found some good free ones. And then also just some other advanced care planning resources, aging and disability resources, things that are in our community here in Washington, so that you can know how to find that information, because we actually have some good information through our state and county, the different counties, but people don't know how to find it or where to access it. So these are the 5 stages of dementia. Depending upon your sources, they may describe things a little bit differently or have different stages. This is taken from the Dementia Action Collaborative of Washington State. They put together something called the Dementia Roadmap. This is a copy of it here. You can actually, at the bottom of the slide there, go and download a copy. I know Cindy was going to try to order some to have here, and they told her that they were being revised, so they didn't want to send out any of these. I have a handful of copies of these. If someone's particularly interested in that, then I'm happy to share those with you. But they propose these 5 stages, the first being kind of wondering and worried, then mild cognitive impairment, and then from there, early, mid, and late stage dementia. And when we talk about these, there's kind of a building on the things that you see in these stages. It's not like you move from one stage, now you have new features so much as the features can kind of build or exacerbate over time. And also the recommended action steps are all going to be consistent. We're going to just sort of repeat them and build on them as well. But for the wondering and worried phase or stage, some things you'll start seeing there is kind of just difficulty performing more than one task at a time, or difficulty with solving any type of complex situation or making decisions in general, what should be simple decisions. I mean, sometimes I may struggle over what I want off of a menu at a restaurant because I like more than one thing. It's different than, boy, I really just can't even focus on that there's different things to choose from here. Start forgetting recent events and conversations, and maybe take longer to just do a task that might be a little bit complex, but generally easy to navigate when you aren't in these early stages, such as maybe using a computer. So from the onset, getting good medical assessment, and the other speakers here are talking about that there are so many things that contribute to why this might be happening that can be easy to treat and reverse. And so knowing that up front, and even in our kind of allopathic world, we can be looking at thyroid function or anemia or B12 levels and things that may make a huge difference and completely kind of erase this stage. But no matter what, to be thinking about planning ahead for if and when this may progress, or if and when some other illness may cause my overall health to decline. So always starting with some advanced care planning and putting advanced directives in place early. And talking to the people that you care about, the people you consider to be family, loved ones, so that they can know that you're worried about this and can help support you through this. And then mild cognitive impairment, you start seeing some difficulties with paying bills. It was mentioned, like balancing a checkbook, maybe preparing a meal. You just can't even kind of get through the steps of how to do it. Early on, we start thinking about driving and when is that safe? And, it doesn't hardly feel safe when we are fully isn't on these roads these days. So all the more it can be difficult for people at an earlier stage than maybe in the past because of the conditions around us, at least where we live here. You start to see a decline in ambition and just forgetting details of things. Maybe, your grandkid's birthday or something like that. Emotions start to get labile, and you'll see sort of an intensity of that as you go through the different stages of dementia. Some of it is the changes in the brain. Some of it's even kind of grieving and awareness of the changes, and that can create some emotions at times. What is good in the earlier stages is to have some type of routine. So anything that's familiar will help people to function well and to a degree of independence if that's established for them. But again, should we be still driving? Things to be thinking about. Again, do we have an advance directive? Can we be working on that? Can we be revising it potentially? And then, again, having a family meeting, and family being whoever you call family. It's not always your biological family. It may be your neighbors or your close friends. And to talk about kind of what's happening and start planning for some safety things, medication management, and things of that nature. It may be something where if you set up your own Medi-Set, you'll take your medications properly from day to day, or you might need somebody else to set that Medi-Set up for you, but kind of making sure that's done safely so you don't forget throughout the day you've taken your medicine and take them again. And start thinking again about how to manage the finances then and how to not be really taken advantage of, because there's a lot of vulnerability for people that are developing any type of cognitive impairment or dementia. People figure that out. And I've known people that, they're giving money to all kinds of causes and things that they can't afford because they don't remember that they can't afford it, or they're just benevolent people and someone's taking advantage of that. And then the early stages of dementia, we start seeing more trouble with time and sequencing events. We're hearing about this from our other speakers as well. Start to forget the names of familiar people and things. You may still be working and find that you just are more awkward at work or more awkward in social situations. It becomes more difficult to kind of engage once the way you once did, and the way other people are comfortable. People just get uncomfortable when these things start developing with other people. Again, more trouble with multitasking. Now, not only is it helpful to have routine and tasks and familiar things to be doing, but people will develop sort of a preference for familiar things. So they'll want to do some of the same things over and over. I remember with my mom, my cousin had asked her, "What can I get you for your birthday?" And she came up with this, I want Lush, some, particular cream from a store called Lush. She hadn't been using this forever, but it was familiar from her conversations with my cousin in the past. So it was just sort of like, I better come up with something. I'm going to have this familiar statement that I put forth. Again, more kind of changes in personality and some sorrow. Some of the suspicion and anger and frustration you see in a way is sort of trying to hide that you're aware of this happening. Sometimes you really don't know. But you can really become suspicious of other people, because if I'm forgetting something, or if you're saying I didn't do something right or forgot something, maybe it's really you. So, it's kind of this trying to justify in a way what's happening. And once again, trouble with driving safely. Sometimes in these circumstances, people can drive half a mile to the store, and they've driven that path for years and it's common. So back to that sort of common things are helpful. My aunt, who's also now developing dementia, she drove somewhere, but they had a detour. So even though it was where she normally would go, she got lost, and it was scary for her. She was like an hour and a half away, and somehow someone helped her, and the police came, and they had trouble trying to reach my cousin because they didn't even know, she couldn't remember the phone number. At least remembered the name. Somehow that all got figured out, and my cousin went and got her. But before those sort of things start happening, it's helpful to start thinking about, should we be doing this still? And continuing with kind of action steps is getting really the right diagnosis and the best health care. So not all dementias are created equal. We're hearing and learning about that. And so trying to advocate to get that is going to be really important. And my experience is it's not necessarily something that we're doing regularly, or it's not necessarily intuitive in our traditional healthcare system to want to make a difference. It's sort of like Dr. said earlier, I'm so sorry, is kind of what we hear, instead of let's try to work on understanding this better so we can get you down the right path for exactly what's happening with you. But really for the individual and the people close to the individual to try to learn all you can. I love that example about the gal that was diagnosed and sort of just told, I'm sorry. And then she said, no, I'm going to overcome this. I'm going to research this and find it out. So there's really power in the individual and loved ones doing that. Safety measures, again, become more and more concerning. Things that we don't think about when we don't have this issue are even like cleaning products in the home. You know, if someone thinks the bathroom cleaner is their hairspray and they're spraying it, or things like this happen that we have to be sensitive to and aware of. And particularly for men, then we start looking at things like power tools and guns and things of that nature. They can get very frustrated and angry at the thought of maybe you shouldn't just have easy access to that. And yet it's dangerous not to be thinking about this and looking ahead. So balancing that, trying to allow some autonomy and independence, but needing to take these safety measures. Thinking about having some sort of a ID on people, whether it's, you know, a neck bracelet or a wrist one. Sometimes we have like medical alert buttons that are also programmable with some of this information too, that have multiple purposes, because then it's a way to summons help if someone happens to be living alone and have something happen. And it's starting to think about at this point, when this progresses, thankfully we have some options that aren't readily known, but we're learning about today to keep it from progressing. But at some point, it will, or another illness is going to cause a progression. That what do you want to do when this happens? How do you want to live? What are the options that are available for how you want to live in the future? As it's kind of normalizing those conversations, because too often we don't talk about it until we're at a crisis point. And at the crisis point, you don't have so many options. And I went through this with my own mom, that she was trying to live alone but not caring for herself, and kept saying, we have to come up with a plan to get you in a place that you choose before there's some sort of a medical emergency and you end up in a place that has an opening or that will accept you at that time. And that is actually what happened. She had developed a urinary infection and became septic at home. And a friend called me and said something about, hey, would you just tell your mom that I'm bringing by her tax papers later? And I said, oh, sure, I'll let her know when I get off work. And they said, oh, I thought you were there with her. I talked to her a little bit ago and she said you were there giving her a bath with somebody. I said, oh no, I'm at work. And so I left work and went over there, and she was just delirious from infection. But she left in an ambulance and never went back. And my brother and I call it, she kind of went on tour to different facilities. So she had some interesting behavioral challenges with her dementia that were an evolution of her personality as well. But we had a lot of challenges trying to get her the right care at the right time. But thinking about these things ahead of time and planning for it's really important. So in the mid-stage of dementia, we see again sort of a progression of these same challenges. At this stage, more and more difficulty with memory. Really probably often cannot remember your own phone number, your own address, start to not recognize familiar people, or you may recognize that you should recognize them. They seem familiar, but you can't remember who they are, or at least what their name is. Sometimes you might remember the relationship, but not the name. Yeah, that's my neighbor. Your neighbor who? You know, my neighbor. So you start seeing things like that happening. Increased difficulty with organizing, planning, following instructions, and then just solving simple problems, kind of like that example of people who live in glass houses shouldn't throw stones. They no longer understand that it's not just about not being not nice as much as that home will fall if we hit a glass building with a stone. Hygiene can become a real problem. People start forgetting that that's important, start forgetting whether or not they've already tended to things. They want to wear the same clothes over and over again. Sometimes can be resist wanting to take a bath. This gal that I saw at work this week, her husband said the opposite was true with her. She kept forgetting that she had taken a bath and tried to take them 5 times a day. Up to 10 times a day, and they had a walk-in tub, so she'd go in and close the door and fill it up and just sit there, which is how he found her that day that she ended up coming to the hospital. But more often it's the opposite, not wanting to bathe, which is a problem because one of the other problems we start seeing at this stage is incontinence of bowel and bladder. And so not a good combination if you don't want to change your clothes and you don't want to bathe and you're having some incontinence. And so having to find ways of normalizing what is necessary to keep people safe and clean and healthy and dignified at that time. This gal I saw the other day, once again, her husband, when I asked him about how often is she incontinent, he goes, I don't really know because she wears those pull-ups. And she's still taking care of those things on her own. But at least that was true. She had an option that made her feel independent and dignified. And yet he needed to have a little more attention to what was happening with that. You do start to see more of this sort of, like I said, the suspicious behavior. Start kind of complaining about feeling neglected by the people who care for you and love you the most. If something doesn't go right, or you forgot something or did something wrong, it must be their fault. This is very common, and sometimes it's a real change in personality for people. So you have very, very easygoing individuals that suddenly are not. Sometimes it's the opposite. The people that used to be much more worried and fretful about things and perfectionists and want things just right, now they just don't care. There's a passivity that can come with that. Some of these types of dementia will also have some actual delusions and hallucinations that become part of what's happening. Or if you have an infection on top of things, then you're much more likely to have more significant challenges with delusions and hallucinations, as was the case with my mother. I knew before she had this infection that she probably was developing it because she called me and said, do you think that this diabetes medicine makes you hallucinate? And I said, not usually, but I wonder if you have a urinary infection. Well, no, of course I don't. I don't have any pain. Well, Mom, you don't always have pain with urinary infections as we age, and particularly with other health challenges. And she just was adamant that it was the diabetes medications, which of course her not taking them properly added to the progression of her vascular dementia. Managing diabetes, managing high blood pressure, and these other things have a significant impact at completely slowing the progression of these conditions, reversing to some degree. But when there is a vascular component, you also can see good days and bad days, and sometimes some significant variance in them. Whether it's the management of the diabetes, the blood sugars, the blood pressures, or just the fact that it's vascular in nature and things happening around you are affecting that, whether you slept well or it's sunny out and you got more sun. So that can be tricky for people too, because on a good day they think, especially the loved ones, they're fine. There isn't anything really going on here, and they may not can report that as the loved one that goes to the medical appointments with them. And so then we aren't getting honest information to people. Had a friend in the past that would go to her doctor's appointments and come home and say, he says everything's fine. And I would always say, but it's not. What you're telling me, it's not. What I'm seeing, it's not. And I went with her one time, and she said, yes, please do come. But when the doctor started the exam and the conversation, and it was back to this, everything is fine, I started bringing things up gently and kindly. And it was sad because she kind of literally backed into a corner and looked like a cat that had just been sort of cornered and was going to pounce at any minute, because truth was coming out and it was scary for her. So, but necessary. So how do we help people get the right information out there so we can know what's happening and manage it and tend to these things? But you definitely start seeing some challenges with sleep. Sometimes that can be like people that are up all night and napping during the day. Sometimes it can be they actually worked the night shift at one point. So asking people about their normal patterns and seeing, is this really normal for them? Or they're reverting to something that had been normal for them. But also sort of this apathy, passivity. So maybe you don't sleep nearly as much, but you're doing less throughout the day as well and kind of less engaged. It's interesting, you can kind of go back and forth to being sort of irritable and aggressive towards the people that you care about and leave me alone, you can't possibly be right about any of this, to following somebody around kind of incessantly. You can't even go to the bathroom. It's like having a toddler, because they're so clingy to that which is familiar and safe for them. Definitely repetitive questions, definitely wandering. Falls start to become problematic. It's interesting hearing about like the retinal scans and the changes in the retina with Alzheimer's that mirror the plaques in the brain, because some of the changes that start happening, particularly at this stage, is with visual issues. And so they may see something that looks like a hole in the floor, and be afraid to walk that way. And so they're kind of stuttering, and then they're more likely to fall. So some of the things we think of doing at this time that can be really important is having a home safety evaluation, requesting that from a home health agency. They can come in and look at things that you don't always think about that may be helpful, whether it's a throw rug that's a tripping hazard or cords that may be, but maybe it's the beautiful, handmade rug that you have that covers the whole floor, so it's not a tripping hazard, but it has these color patterns that are more likely to trigger someone to think there's a hole in the floor. And there's just things like this that you can't possibly think of all these things without somebody helping you, but that is part of a home safety evaluation. And they may talk about things like, is that walk-in bathtub the best thing now? This gal I saw just the other day, the husband said, I think I'm going to turn the faucet off in that bathtub and have her use the other one where she can stand or sit but not be submerged in the water. So it's just things like that. To have help thinking through that is really important. Continuing to talk about family, about what's happening, and planning for next steps. This is a stage where it can be really hard for someone to be living with an individual with dementia solely and being the only person caring for that individual day in and day out. So we'll see, I have dear friends right now that are almost 95 living together, where he does have this kind of middle stage dementia, and her health is having some challenges, and she's very worried about him out surviving her. And so needing to be planning ahead for kind of what are we doing is really important. And also to be thinking about her health and not just his health, because if that caregiver goes down, you're the only caregiver, then what? How do we care for these people? And it's tricky about, when might you consider being in some type of a congregate living situation, assisted living or memory care, and what to do when you have a healthier member of the couple that maybe doesn't have to be in that setting, but we want to keep them together. There's a lot of things to think about. So talking about it is, the first step towards getting the right information. And there are placement specialists out there that will meet with individuals and families and talk about all the options, all the ranges of options that are available in the community. So you can start to think together, plan together about what's the right next step at the right time. And then how do you afford it? You may or may not have a long-term care insurance policy that may or may not cover the type of care that you need. And you may or may not have the right resources and savings. And so then it's an issue of, if you're trying to protect the surviving spouse or family member, having the right plan in place that's done properly legally to protect the assets and also have resources to pay for care or to apply for assistance to pay for care. So, home and community services, again, through the county, is a place to start getting some of this help, and some of the links at the end of the presentation you can look at and look ahead to just even know who to ask to start thinking about some of these things for sure. But again, on top of this, it's continuing to talk about how an individual may want to spend their time as they go through the progression of their illness and other complications that start coming up as well, is what kind of things you're going to want to do or not do as you are getting closer to end of life, or at least considering that. And I always say, talking about these things ahead of time and having a plan for when they may come in the future doesn't somehow jinx the future to coming sooner or cause these things to happen sooner. I would actually argue the opposite is true. When you think about it, have a plan, then you can live in the moment and just sort of know that when I get there, I'm going to have what I need. It's going to be set up. It's going to be thought of and thoughtful, and meet my needs at that time. Because there seems to be a fear of talking about these things, that it somehow is going to cause the future to come sooner. So in the late stages of dementia, then we start seeing, again, sort of a progression of all these other challenges and complications, not recognizing other people, not maybe calling them by name, or you're calling your spouse, your wife, now you think it's your mom, or you think it's your daughter. One of the others but you're probably going to know that it's someone important to you and that you love and care about them. So that's important to remember that and not take offense. I know I took one of my boys in to see my mom when she was living in a memory care facility, and she got so excited and said to one of the other residents there, "Oh, this is my nephew." And my son went, "Nephew?" He just seemed like so upset. And I just it's okay, we'll talk about this later. But clearly she knew it was someone she loved and was happy to be seeing. Definitely increased difficulties in communication starts happening, and can progress to sort of a word salad before it leads to eventually being very few words that you actually can remember. Kind of a quick funny story is when my mom was in memory care, there was a young patient that was there, one of those earlier diagnoses that we were hearing about, who would wander around with t-shirts and a jean, and she looked like an employee. My brother, who has nothing to do with anything healthcare, in fact, he would joke about passing out in health class. He calls me one day after visiting and said, "Oh yeah, this lady wandered in, and I was sure she worked there, but she was talking and it made no sense. It was just all these random words, and she was pointing and looking around, and I just didn't understand." But then she picked up the box that had a picture of a bedpan on it and said, "Isn't it beautiful?" And he said he figured out then and there that, oh, wow, I think this is another patient and not an employee. And so I was laughing hysterically when he was telling me the stories, and I told him what word salad was. And to this day, he loves that term. It's like, word salad. But actually, eventually, they become completely nonverbal. Or early years working as a nurse in a nursing home, had a patient that had advanced Alzheimer's, and she would just sit in her chair and laugh all day. She was always happy. She just laugh. And one day I came in and I heard her sing a whole verse of Jesus Loves Me out of the blue. It was like, wow, which was also powerful because it was in the recesses there. Something triggered it. I never heard her do that again, but she had this moment. And there's actually a term that I've heard recently come out that they call terminal lucidity, where when they're nearing end of life, all of a sudden there is some clarity. Some of these things can come up, and they're just kind of gifts if they happen. They don't happen all the time. But I was sure blessed that day when that happened. But they also become totally incontinent at this time. Their ability to walk becomes challenged. Most of the time they actually can't. They become chair and bed bound. Eventually at some point they can't even sit up in a chair. They start falling over. We start seeing some challenges with swallowing, just the ability to coordinate the task. It's somewhat complex. So at these stages, it's remembering what to do, and practically what's happening physically can become something that you just can't do. That is one of the reasons why they start to have more infections, particularly pneumonia and urinary tract infections. Is some of it is, swallowing impairment and things getting in the lungs. But it's also just the whole change in the immune system in the body. Infections become more common as well. Can definitely see some deep emotions at these times too. Sometimes just moaning or screaming or flailing or just carrying on. So if you ever do visit a memory care facility, you will see all of that. And again, sometimes it's just the deep sadness to what's happening. I had a pretty powerful experience with a wife of a patient in the hospital a few months back that he was having some of these emotions. And when I talked to her a little bit about had he had any trauma in his past, she brought up a lot of things that had happened early in his life and how she could actually see in some of his moaning and screaming and carrying on, it was a reflection on some of these things. And so I said, well, maybe just try, rather than, trying to get him to stop, try to just be with him in that, and just say, I'm sorry you went through that, or some of these things. And she was so excited the next day because she said, it worked. How come no one ever told me this? Is that people who have had trauma in the past of various sorts tend to have more of these challenges towards the end of life, or if they're developing dementia. And trying to correct them or tell them that it wasn't real or some way, or think that it's completely irrational, is not therapeutic. Recognizing that it may come from one of those places really can be. So what do we do to help people at this stage? Really allowing plenty of time for very simple tasks. Not unusual for it to take an hour and a half to eat a very small meal. But that one-on-one interaction, if we're helping them do that, is really therapeutic for that person. It's socialization that they're not getting in any other way. Thinking of being present and together in ways that don't require sort of conversation or recall or good comprehension. So looking through photo albums, music, smells, favorite tastes, kind of all these things are very, very therapeutic. And if they're talking about their loved one that died 50 years ago, rather than reminding them they died 50 years ago, sometimes you can just say, well, tell me more about that person. And that can be therapeutic if they have the ability to communicate. Sometimes that opens the door to communicate actually better than they normally have been. So it's some of these things that we just aren't necessarily always aware of. Continue to talk to healthcare providers about what's happening. Continue to talk about what's important for them to continue to receive in terms of medications for other conditions. There are times when, as we anticipate the swallowing becoming, more challenged, we want to eliminate the things that are less important so that we're more likely to get the things that are more important. So that's an ongoing conversation. Continuing to talk to close family and friends about what's happening and planning for next steps and if there's a need for more care. Interestingly, there comes a shift where once they are mostly bedbound and they're no longer wandering, in some ways it's easier to have them at home if you've got the right support and care in place than at the earlier stage when they're wandering and resisting. But maybe not. Maybe it really needs to be in a care facility. Having home and community services come out, or talking to them again about the resources that are available and getting their input on your specific situation is going to be helpful. Hospice and palliative care can be helpful, but kind of as I mentioned earlier, in our community right now, we don't really have palliative care in the community. We only have it in the hospital setting. But hospice is for the very, very end stages. And with dementia alone, you literally have to be kind of not eating, not talking, not getting out of bed, And to really get to that stage, there's a lot of kind of a work up to that point where you need help long before that. And I think an important lesson to learn is even people with the end stages of dementia have a capacity for joy, and even if it's momentary, that picture really made them smile, it's very real in that moment. And so don't ever feel like your presence at those times and in those ways are without significant meaning, because it really is important. So when it comes to cognitive assessment and how we do that in the healthcare system, we need to be very clear on the words we use, because competency is a legal term. I hear a lot of the times, in fact, when I was in my doctoral program working on my project, my faculty guide kind of insisted that every patient I saw, I had to determine their competency. And I kept saying, no, you don't want that. This is a legal term, and it's much more binding and kind of universal. But decisional capacity is a clinical term, and any clinician can assess it. It can and will fluctuate, particularly with the type of illnesses you have, and it's specific to a question. So you don't have capacity for everything at large, you have capacity for specific things. And, someone can definitely have the capacity to decide between chocolate and vanilla ice cream, or maybe they can decide who they think would best speak on their behalf if they couldn't speak for themselves when it comes to making medical decisions, but they can't really understand the complex medical decisions that need to be made. And so, it's really important that we kind of know the difference on these things, and that we do repeat these assessments over time. Some days are better than others. If you're acutely ill, it can be particularly poor. I see people in the hospital where they may have delirium on top of dementia, and it's clear that, people need to keep those distinctions clear, because people will tell me, oh my gosh, my mom developed dementia in the hospital, or my mom's dementia got so much bad. Well, acute delirium, meaning the acute illness is causing the change in your cognition, and it will get better as your illness gets better. However, people who have dementia, it tends to be more pronounced, and it tends to take longer to resolve over time. But people in the hospital, I'll see, have these MOCA tests done, and a couple of days later, significant improvement from 12 to 28. So then it helps us understand better too that no, this isn't a dementia thing, it's a delirium thing. So to assess decisional capacity, there's 4 main things you're looking at. Can they actually communicate a choice? Do they understand information about the choice they're being offered? Can they appreciate the actual situation and its consequences? And can they reason about options? And so, again, if you're talking about specific to a choice at hand, more often than not, what I see is someone could tell me, I really trust my daughter Beverly more than anybody to help make these decisions in the future, and I trust her because she's the one that's always been there for me in the past, and maybe she's worked in healthcare or whatever it might be, and I really don't want this other person because I saw how they handled XYZ, or so there's just a way to assess that. And that same scenario they may not be able to talk at all about. So, what do you want? Chemo or no chemo for this cancer? That would be completely a different thing that they couldn't understand. But if you want to see if they're understanding, ask them to paraphrase the information, compare options and outcomes, and then tell them what their preferences are and a reason for those preferences. So advanced care planning is something that happens as often as it's needed. It's not a one and done thing. Sometimes it can be, but we can't assume that it is. And it really is anytime there's a change in someone's status and condition and health in their dynamics, kind of readdressing things can be important. Estate planning is equally as important, but it's very separate. It's not healthcare related, it's more financial and legal. So they often go hand in hand, but they're addressed differently by different people. So I do advanced care planning and not estate planning. 4 things to consider as part of advanced care planning are getting information on the types of life-sustaining treatment that's available, making decisions about treatments for the future, in the future, if diagnosed with a life-limiting illness. And anybody at age 18 can be thinking about this, because even if they don't have a life-limiting illness, sudden illness and injuries happen all the time that we didn't think of. So thinking ahead is always good. Then completing advanced directives to document these preferences. And then make sure these preferences are shared with loved ones and with your healthcare providers. Too often I see people that say, yeah, I have those directives. They're locked up in the safety deposit box at the bank, which doesn't help people in your healthcare community to know how to care for you. But for some reason, I think they just lump it in with the estate plan and don't realize that it's important to give it to the right people. And here in this area, the major health players, you have Providence and MultiCare. If you provide your information to one of those organizations, it may not be readily visible to the other organization, even though they have the same electronic medical record. It's kind of a pet peeve of mine. I've worked on locally and kind of on the state level to try to make that better. But that's just to say, if you see healthcare providers in multiple systems, make sure they all get copies of your directives. And I always say, use the magic word, please scan this. Because if you provide it to someone who looks at it and says, thank you very much, maybe they even put in their note that they reviewed it. But if it doesn't get scanned, it tends to get shredded and not be part of your record. I even see people all the time that they bring it to the emergency room and it doesn't make it from the emergency room up to the floor. So just to try to think of using those words. Scan these, please. And everyone gets one. So there are some things that are very specific to dementia when it is left unchecked and not mitigated that are part of considerations as you are looking particularly towards the end stages of dementia, and to be thinking ahead about what kind of interventions you may want when these things come to be. Because dementia is a progressive neurological terminal disease. Fortunately, I love learning about ways to kind of mitigate that and reduce the risks, and in some instances maybe completely reverse some things. But for the most part, we see people that have more advanced disease anyways because they didn't get these early interventions. But people don't think of it that way. It's like people think of ALS or multiple sclerosis. Those are neurological conditions. Well, so is dementia. It does lead to the inability, as I said earlier, to understand and coordinate the task of eating. So this dysphagia starts to create problems, as we also mentioned, with aspiration or just not eating sufficient to kind of sustain life or to not prevent, significant weight loss. So then artificial nutrition and hydration need to be considered when this happens. Things to consider is it's not a simple kind of fix. Feeding tubes for people that have dementia are problematic in many ways. They're uncomfortable. They'll cause some irritation, agitation. They don't keep you from aspirating your own saliva, because that starts to happen as well. One of the lung doctors I work with likes to tell people, and it's a vivid kind of picture that we make about a liter of saliva every day. That's going somewhere. And so if it's going the wrong way for people, no matter what we do elsewise, it can be a problem. But also if you put formula through a tube, it can regurgitate back up and get into the lungs that way as well, because when this coordination of the task of swallowing is impaired, it's all levels of the digestive tract too. But if you're dying from the end stage of dementia, you're not starving to death. You're dying from the dementia. So I think clarifying that is really helpful too, because people the task of eating, and when they try, it's causing a pneumonia. That doesn't mean that you're starving to death. It's kind of the consequence of dying from the illness, not the cause. And so I think that's an important distinction to make. And then also this kind of tendency to have pneumonias, partly from the aspiration, partly from the changes in the whole body and the immune system that are part of the advanced stages of dementia and urinary infections. They're very common. And in actuality, it's often what people with dementia die from. So, are you dying from the infection or with the infection? Really it's the progression of the dementia that's causing these things. You don't always have to treat to fix the infection. You can treat to make sure you're not uncomfortable. And in some instances, fairly common when these infections occur, they are not actually causing distress or discomfort. We figure them out because we find them in the hospital with an elevated white count, and we start doing x-rays and checking blood work and urine and such, which at some stages that may be very appropriate and they may be easy to reverse and treat. But eventually over time, when we're retreating over and over again, we're not fixing the underlying problem. The antibiotic may fix the infection then, but it won't fix the source of the infection. And then sometimes we have complications from lots of antibiotics, and then we get other infections from that, C. diff, Clostridium difficile. That did happen to my mother too. And she was in a facility where they were insisting upon giving her an antibiotic before even checking for the urine infection. And I told them, no, the antibiotic you're giving her, you want to give her, has never worked for the type of things she's grown in the past. And she's had C. diff 3 times. Are you sure you want that in your facility? But it is a reality that you could potentially forego treating an infection. And these things are kind of on a scale, and it's not right or wrong, and it's going to change over time. It's just to even think alternatively about, do we always want to try to treat to fix these things? When might we treat for comfort instead? There's a really great book that I highly recommend. I have just one copy with me here. I wish I had more. Hard Choices for Loving People. It's actually written by a hospice chaplain, but he talks about all these things and the complexities around the choices that need to be made. And it just really helps people to think objectively, or to then actually have a reference point. Like if I talk to them and they say, boy, no one's ever explained this before, I got to tell my loved ones. And then they go, I can't remember what you said. I can't explain it to them the way you did. It's a really good tool to use. So the post form, every state has one. This is Washington's. I have a copy here. This is an advanced care planning document, but it's not an advanced directive. It's actually a medical order. It's completed by an individual or their representative and a provider who knows them well. And it is a medical order for outside the hospital. So if they're at home, assisted living, nursing home, having this form then is a directive to the emergency medical system or the medical people involved with their care as to what you want, very specifically to CPR and different breathing support. So it's what to do if you've died. Heart has stopped or breathing has stopped. And so hopefully if you work in healthcare and you're a provider, you've seen these forms and you've helped people fill them out. I see them all the time filled out in very creative, unique ways that don't make sense. And it's not because the patient or their loved one filled it out, because a provider had to sign it with them. It's not a menu. You can't check all the boxes. I see that sometimes. Just a couple things to really point out. Section A, where it talks about you either attempt or don't attempt CPR. On the first one where it says, yes, attempt CPR, it guides you to go down in the next section B to select the full treatment option, which includes being on a ventilator or being intubated. A lot of people will say, I want CPR, but I don't ever want to be intubated. And they need to know it's part of CPR. And so having that discussion and filling out the form correctly, because I see it all the time where sometimes it'll be checked yes to the CPR and then select treatment or comfort focused treatment, one of the other options down below, which they're just not congruent. The select treatment one is for people who may say no CPR or ventilator, but I'm still wanting to get treatment. I want to go to the hospital, get antibiotics and be on a monitor, get fluids and such. But then the comfort focused treatment at the bottom is for those who actually don't even want to go back to the hospital anymore. And that's a point of confusion too, because some people say, well, of course I want comfort focused care. I've seen it checked, yes, CPR, and then yes, comfort focused care. because we're not thinking we want the uncomfortable care. So it's not my preferred choice of wording, but it is the words that we use that. So to be intentional about these things, which is why it's also something that's worthy of a conversation and not just handing it to people. And too often I see when loved ones are, moving into assisted living or into a nursing home, it can be part of all the paperwork to fill out, and you're just kind of left to do it on your own. And then a provider might come behind and sign it and not even look at what they're signing. And then I see it in the hospital and say, this doesn't make sense. It's not directing care the way we want to. So the back of the form, I don't have up on the screen, but it does have an optional section to address tube feeds, which I'm glad if you work in healthcare and you have any old versions of this form in your office and they show up all the time. This is a 2021 one. This is the most recent one, but older ones are not as much as this has some challenges, it's even less well worded on those other ones. But they took the tube feeds off of the front as well as a clause about antibiotics, because reality is those are never emergencies. I'm not looking for your form, or the paramedic's not going to have you in the ambulance going, I wonder if they want a feeding tube. It's just not, doesn't fit. So I recommend get rid of old versions if you have them. Don't try to, be Scotch and save them, but and then advanced directives, there are two main ones, living wills, and then the durable power of attorney for healthcare. The power of attorney for healthcare, I think, is always the most important one, because the living will, you can put in writing things you may want or not want, but you can't think of every possible scenario that would present. So you can't cover everything. But a person you know and trust that you appoint to speak for you can know who you are and what your values are, and take information provided to them about what's happening medically in the moment and help make decisions on your behalf. The good thing is that the durable power of attorney for healthcare is actually a little bit easier to complete. Both of these documents need either notarization or two witnesses to sign it. The durable power of attorney for healthcare, I help people fill them out in the hospital all the time and can sign as a witness. So a lot of healthcare, we can fill them out in clinics with people as witnesses. A lot of us in healthcare are able to do that. When you can't do it is if you work at a place that somebody lives. So assisted living, long-term care facilities, those staff, if you work in those settings, you can't be a witness. Or if you work for a home health agency that goes into the home, you also can't serve as a witness. However, a living will, rarely can someone in healthcare actually sign that. So that is a little bit more complicated to complete. Washington State Medical Association does have some forms online that you can download. There's a fillable one, and then there's some that are non-fillable that you can print. And so it's good to be able to go there. I think too, back to the post forms, Washington State Medical Association online actually has a PDF of 14 different languages. So that's helpful to have. And the way they normally have you fill that out if you're doing it with someone in another language is you're giving them a form to read in their language, and then you're filling it out on our form because we can't necessarily read their language. So the legal surrogate decision maker, this can vary a little bit from state to state. So this is how it is in our state. But this is if we don't have a power of attorney. If that was never appointed at some point in the past, only an individual can do these documents from themselves, advanced directives and powers of attorney. So if we've missed the opportunity where someone has the capacity to make that decision, then now we have a legal precedent in the state. The top of the hierarchy is a court-appointed guardian. They would always take precedent over any other decision making that may happen. But directly underneath that would be the durable power of attorney for healthcare. Most of the time, if a durable power of attorney for healthcare is in place when someone can do that for themselves, we don't ever progress to the point of needing to get a guardian appointed by the state, because that can be a long, complicated process. But if there is no power of attorney, then you're married, it's your spouse that's your default. If you're not married, it's adult children. If not adult children, it would be adult parents. From there, adult siblings. until 2019, that's kind of where it ended in our state. Then they, after that, added some of these other groups, grandchildren, nieces and nephews, aunts and uncles. There's even a special declaration that can be filled out that's good for 6 months. So if someone happens to not have anybody that fits any of these categories, and I unfortunately see this on occasion in the hospital setting, and you happen to be a good friend or a neighbor or someone who really knows them, you can step up and sign a declaration that says, I'm willing to be their decision maker for this period of time for 6 months. And it's actually legally acceptable to do that. The challenge comes when you have anybody available in any of these categories, if there's any complexities in the relationships with the people in these categories. Because, for instance, adult children, it has to be all the children agree. It can't default to the oldest child. It's not a majority wins. Everyone has to agree on what to do. And, I had people tell me things like, my kids wouldn't even agree on what to have for dinner at night, let alone decide what to do about mom if we're in an emotional situation where she can't make a decision for herself and I'm doing it for her. So there's a due diligence that has to happen too, because I also have people that will tell me, well, I have 5 kids, or this other person has 5 children, but we don't know where 3 of them are. You have to put some effort into trying to find them. At some point, you have to say, we put effort in, though. Sometimes you just can't find these people. But this is just to say, this is what legally needs to happen. Too often, I'm the bad guy at work because I come in, and even in the hospital setting, they maybe weren't following this. And all of a sudden, this granddaughter, who's the caregiver, and making all decisions, realizes that she's not the decision maker, and nobody else had kind of pointed that out yet. So I don't want to be the bad guy. I want to have people be prepared ahead of time and kind of know how this works. But we do have to educate each other, even in the healthcare arena, because people often don't know this all the time. They think it's the path of least resistance in some ways. So here I just have some links to some pretty snappy, easy to follow videos on advanced care planning. They're really just like 1.5 minutes each. They're really helpful if you're ever trying to show family members, loved ones, or just patients and families. The Prepare movie is a longer movie. It's actually designed to be able to be shown at like gatherings at churches and things of that nature. This 6-minute CPR video is actually a very good one that you can download for free. I used it when I did my doctoral project and I was meeting with residents in assisted living communities. It's just really well done to show what CPR looks like, because otherwise it can be hard to fully explain that to people. Some other good resources in our state, Honoring Choices Pacific Northwest, they kind of 1.5 years ago or so, they're no longer an active functioning group, but their website does still have some really good information on there on CPR, breathing support, feeding tubes, things of that nature. I already pointed out the Dementia Roadmap, where you can go and download some information from them. The Conversation Starter Kit is a great resource. You can also go to their website and download a document. And why this can be nice is you can have people downloading that in different places. And it kind of looks like this, but it has a way of people being able to talk through what's important to them and kind of rate it and document it, so that if someone is speaking on your behalf in the future, they know what your wishes are. And it just says things like this: if I'm diagnosed with a serious illness that could shorten my life, I would prefer, on one end of the spectrum, not to know how quickly it will progress. On the other end, I want to know everything. And so it allows people to kind of rate the things that are important to them. The Center to Advance Palliative Care requires membership to access most of their learning modules, and I have membership through my employer. It's very interesting that they have 2 free modules to anyone that's not a member. One is just something that goes over the fundamentals of palliative care. The other is supporting caregivers of people living with dementia. Kind of pretty profound that they recognize that this would be an area that people aren't getting a lot of good support. So it's a free module that you can look at as well. That's very well written. And I would say, I think the caregivers of people with dementia are kind of unsung heroes out there. There's so many hours of care and time donated and given to people out there with very little support on what to be doing. And so if we can support the caregivers, that's really important. And then here are some links to, as I mentioned, just the Aging and Disability Resource Center, different resources that are available in our community to look at there. And that is really it. I think I got through okay. I think we were hoping to leave a little time for questions, maybe more than some of the earlier sessions. If there are any. Fig Tree is, it's actually a free resource put together kind of for all interdenominational, gets published and sent to different churches and things, but it just lists resources in the area. Housekeeping or, legal or all kinds of things that you may not even think of. So you can go to the website, but I know, I can't tell you how, but you can be on a registry to have it sent to you too for all different types of churches. So it's meant to be supportive to people in faith communities, but it's for everybody in the community. I think it covers a lot of Western Washington or Eastern Washington. Yep. It's a great question. She's asking, how often are people limited simply by finances? That there's resources out there, but they can't afford them. And unfortunately, often. And too often I see people making decisions based upon a financial need more so than what they think is really best for them. For instance, in the hospital setting, if you've been in the hospital for 3 days, you can qualify for a short-term rehab stay that your Medicare will pay for. But if you don't really have the strength and the energy to do rehab, or don't really want to, you're just too tired, you sometimes choose to because then it gets you a little bit of time paid for in a facility by your medical insurance. And medical insurance doesn't otherwise pay for you to go to a facility. So it is part of why the financial planning ahead is important. And so that if you don't have resources, you're trying to apply for what you might need sooner than later. One of the resources that I tell people about all the time that they often don't know about for our veterans is if you serve during a wartime, you and your spouse can get what are called aid and attendance benefits. You can apply for it online. You go to any VA website and look up aid and attendance. It actually gives you some money to help pay for caregiving. There's a process of applying and such to go through, but there are things out there that we simply don't know about. So that's why I think sometimes connecting with home and community services and having somebody connect you to the things that are, available that you don't have to pay for, or help you to properly align your assets. Because I think the other thing I see that's really problematic is people are so afraid of, I've got to sell the house to pay for mom's care or the spouse's care. It is a reality. It's really hard. So many people in our country have financial destitution because of medical costs. And caregiving is a big one of them. And with dementia, it's huge because sometimes it's a long period of time.
So I have a comment question combined. If you're thinking of helping a family member do their health directive and you go online to get the forms, make sure you get the ones for the state they live in, because there are variables. And when I helped my mom with hers in Arizona, the state health department takes a copy of that. So if she ends up in a hospital in the state of Arizona, it comes up with her records. Is there any talk or movement towards that happening in Washington State or just across the board?
Great questions and comments. So if people didn't hear her, she was saying being clear on getting the right documentation for your state, for the state you live in. And if you move states, updating it to make sure you have a copy for that state as well. In this area, we're so close to Idaho. People are sometimes in the healthcare system across there. So yes, unfortunately, I mean, fortunately and unfortunately, Arizona and some other states have much better systems in place to kind of download the documents once they're completed so that they're retrievable. And if you are to get a generic form, for the healthcare power of attorney alone, it's going to be the same across any state. But some of the other directives and things can vary some. In our state, there are people that are looking at this, and every now and then I connect with a meeting of people that are looking at this to see where we're at. It's not making very good forward progress, unfortunately. I mean, there was a database created many years ago, actually, to put post forms and power of attorneys in. It just didn't get very good momentum for use. So I think the starting place that we're looking at is to at least have the electronic records we do have more visible information across the systems, because like Epic is it's used the most across the country, definitely the most in our state. So to have documents downloaded in there that we can't even see between, going to Sacred Heart and going to Deaconess Hospital doesn't make sense. I actually personally am talking to the person who works for Providence that is head of this, because they're a bigger organization across more states. They're supposed to be trying to help me look at how to improve that. But right now, it's just not a good situation. And I wish I had a different answer or a power or ability to change that, but haven't been able to.